presentations. My name is Dr. Najd Al-Hamza. I'm dental intern from Riyadh Al-Almi University, and today I will be serving as your moderator for this morning's scientific session. In this session, there will be 5 presentations. Please set your cell phone and vibrate during the session. And before we get started, I would like to introduce our session chairperson, Dr. Samar Al-Hayek and Dr. Uhud Al-Harthi. Dr. Samar Al-Hayek is president of Saudi Craniofacial Anomalies and Cleft Society. She is head of the Cleft Lip and Palate Center in National Guard Hospital. She is consultant orthodontic in Ministry of National Guard Health Affairs and board member of World Implant Orthodontic Association. She is fellow in International College of Dentistry in Maryland and faculty member of the Saudi Board of Orthodontics. And Dr. Uhud Al-Harthi is a restorative consultant and director of the Academic and Training Affairs in Eastern Riyadh Dental Complex. She has received her baccalaureate degree in dentistry and oral surgery from King Abdulaziz University in Jeddah in 2001. Then she worked at the Ministry of Health in Riyadh in 2005. In 2013, she awarded the Saudi Board in Advanced Restorative Dentistry. Finally, in 2017, she joined the Saudi Board as part-time clinical supervisor in Al Yamama Hospital. Now, moving along to our session, please welcome chairperson for the first presentation, Dr. Samar Al-Hayek.
Bismillah ar-Rahman ar-Rahim. Good morning. First, I thank you for the nice presentation, and I'm very pleased and honored to be invited today to witness, inshallah, your success in organizing this conference. I heard yesterday the number of participants was impressive, and hopefully, inshallah, today it will be the same. The first lecture for today will be presented by Dr. Asim Al-Ansari. I'm very pleased to present him. He received his dental degree from the College of Dentistry, King Saud University in 1999, obtained his Master Dental Sciences in Prosto from Lund University, Center of Oral Science, Malmö, Sweden in 1998. He got his certificate in Advanced Graduate Study in Dental Public Health and Doctor of Science in Dentistry at Henry Goldman School of Dental Medicine in Boston University in 2002. Dr. Al-Ansari has been an adjunct assistant professor at Henry Goldman School of Dental Medicine, Boston, since September 2015 till present. He is the Vice Dean for Academic Affairs, College of Dentistry, University of Dammam, from January 2011 to present, and an Associate Professor, Department of Preventive Dental Science, College of Dentistry in the University of Dammam since January 2016 till present. He's a member of different departmental, college, and university committees at the College of Dentistry, University of Dammam, and a member of different professional organizations and associations, and currently one of the board members of the Saudi Dental Society. Dr. Al-Ansari published researches in referee journals. He's also attending several local and international conferences and continuing education courses, and he's a member of different professional organizations and associations. Please welcome with me Dr. Al-Ansari.
Bismillah ar-Rahman ar-Rahim. Good morning, ladies and gentlemen, and thank you very much for being here this morning. It is an honor and a pleasure to be participating in this distinguished meeting, and we hope that it would be of value to the whole nation. The presentation that I have today is about dental caries. We're trying to look at caries through the GIS eye. And I just want to make a small note that our university's name has changed from University of Dammam to King Imam Abdul Rahman bin Faisal University just about a year ago. So today, without further ado, actually, we all know that we have a major oral health problem, particularly the extent of dental caries in Saudi Arabia. And I would say that it is a major health problem rather than being an oral health problem because of the magnitude and the extent of the disease that affects millions of people, I would say, in the country. Although we know that it affects a huge number of people in the community, but I would like to ask, what do we really know about dental caries in Saudi Arabia? We know that it is prevalent, but we don't really know how much prevalent it is. We don't know exactly the numbers because we don't have, as we will say, a national health survey and surveillance system. What did we do to address the problem? In reality, we did a lot, but what we've done is not organized. What we've done is not systematic. And that's why we keep on saying that the issue is big, the issue is dangerous, the situation needs to be addressed and treated, but there is no established system to address the problem so far. Most of what we do is therapeutic. We treat patients. We have health centers everywhere, we have hospitals, we have specialists and dentists drilling and filling and restoring teeth and function, but we did not address the problem as it should be. Although there are many efforts and to address the problem of dental caries from the preventive point of view and the national point of view, but these efforts are all individual or localized. There is no nationwide system to look at the problem and address it properly. So, as I mentioned, we don't have surveillance system in the country. We don't have national oral health survey. So far. The last survey that has been done is about 35 years ago when I was still a student, and I won't tell you when I was a student, but it was when I was a student. And since then, I don't think anything happened. Yes, maybe people at that time tried to use the information that was gathered to come up with a plan and with the system, but it seems that it didn't work as it was supposed to. The lack of oral health, national health surveillance system and national survey leads to inadequate information about the geographic distribution of caries in the country. So we wouldn't know where is the problem or where is the situation, which areas have more needs than the others. So that is, without a surveillance and national system, we wouldn't know that. And hence, we would have difficulty planning services, recruiting the needed number of persons to address the problem. So without that information, we wouldn't be able to move on and establish something meaningful. So based on that, the objective of this presentation actually is to try to investigate the geographic distribution of caries-related factors. So we try to look at the data that we have and try to look at it from where does it exist, in which areas do we have information about caries. What factors affect the presence of data in certain areas compared to other areas? And those areas that have more information than others, why is that? Why some areas have more caries data than other areas? And then we'll end up with a proposal of a model that I hope would work and see how to move on with that. The methodology that was implemented in this project is actually based on data related to caries. So we try to find data about caries. Whatever data that was available about the country was used, and all the data was entered into a GIS software in order to try to see where caries exists, and then to try to understand the spread of caries in the country. And based on that, suggest a certain model to help really address the problem. Caries data was basically gathered from literature. In recent years, in the past 5 years, there were 3 major literature reviews that were published that covers all the studies about caries in the country that goes back about 15 years ago. So the data that is used here covers a period like from the year 2000 until present time, something more or less. The first study is by Dr. Aqil, and this is a very highly cited paper in Saudi Arabia because it covers really many of the aspects, and it's comprehensive enough to use as a means of showing how far or how big the extent of caries is in Saudi Arabia based on studies. The second paper is another meta-analysis of dental caries by Khan and his colleagues, and it's also a comprehensive document about caries in Saudi Arabia. And the third is actually a literature review that I have published a few years ago also about dental caries in Saudi Arabia. So these are the 3 most recent publications about dental caries in Saudi Arabia. It covers all published surveys about dental caries in Saudi Arabia across various age groups. In addition to that, we went to PubMed to look for early childhood caries because that particular issue was not addressed, was not collected properly in these 3 literature reviews, or maybe data wasn't available for them for some reason, because most of the, it seems that most of the people focus to the school age children rather than the early childhood. So we did PubMed search particularly for that. In addition to data, scientific data, we went to several resources to collect data that would aid and would help in having the whole picture, the big picture about the situation in the country. We went to the Ministry of Interior website to officially locate the administrative regions in the country. And there are 13. Someone would say, okay, we could find this information on Wikipedia. And I would say, yes, of course. But having such information from the official entity or body in the country is the way to go. So we have 13 administrative regions in the country. We used also the recent publication by the Saudi Commission for Health Sciences. This report came out about a few weeks ago, and it discusses the manpower needs in the country for the upcoming 10 years and forecasts how many dentists and healthcare providers in general do we need. And we used exactly the number of dental schools in the country. That was an indicator that we wanted to look at. And we have 27 dental schools here in the country, 19 governmental and 8 private. We also used the General Authority for Surveys, and in order to find information about population. The population of Saudi Arabia as of 2016 was 31,742,308 people. And in addition to that, individuals with university or higher education are about 3 million people. So about 10% of the population, more or less, have university or higher education degrees. We also went to the Saudi Geological Survey, and this is a 2012 publication. That's the only one so far available. And usually these publications don't come very frequently. We try to find out how many, the percentage of Category A governorates in every region. In Saudi Arabia, those 13 administrative areas or regions are divided into muhafadat, governorates. So, and those governorates are divided into or categorized into A and B based on services, population, etc. So we wanted to know what is the percentage of المحافظات من الدرجة ألف الفئة ألف. So it happened to be about 46% of the governorates are category A. Also recently there was a publication by, this is in 2017, by Al-Bakr and his group about the dentist workforce in Saudi Arabia. And from this publication, we could able to find a dentist to patient, dentist to population ratio based on the number of population and the number of dentists available, and it happened to be one dentist to 1,879 people. And ironically, it is from this publication that I was able to get the number of dental public health specialists in the country. They are 136 according to the publication. The irony is that this number does not exist in the report of the Saudi Commission for Health Sciences, health specialties. There are a list of all clinical specialties, but there is this was not in the publication or the report of the Saudi Commission for Health Sciences. Last but not least is the annual statistical yearbook of the Ministry of Health, from which we got the number of dentists, and according to the report, there are 3,377 dentists. Okay, all this information, the scientific data about caries and all the other information were analyzed using three systems, or three ways. The GIS, the ArcGIS system, logistic regression analysis, and Pearson correlation coefficient. And what we've done with this is that we actually, like most GIS systems, ArcGIS provides, when the system is fed with the information that you gather, it draws a map that tells you, based on the numbers you had and based on the other factors that you fed the system with, tells you where things happen more than other places, gives you an insight of how things are spread in the country based on the factors and the numbers that you gave it to the system. And then in regression, we assess the strength between data availability and the various factors that would affect that, so that we want to say, in certain area, why does caries seems to be more caries data than other areas? What are the factors that seems to explain that? And finally, we used correlation to investigate the association between the number of dental schools in the region and data availability. So we try to see if there's any correlation between an area that has more number of dental schools, does it have more data about caries or not? So what did we find? Excuse me. Based on the two surveys that the three literature reviews that we used, I'm sorry. We had 19 studies about dental caries. And one would say, okay, the three reviews have only 19 studies. Yes, there are many. These are the studies that are without the repetition, because there are a high number of repetition among the three reviews, and there are 9 studies about early childhood caries in Saudi Arabia. So these 19 studies surveyed about 26,000 people. This is not a small number by all means. It's a huge number for a survey, for the cumulative number of people who were surveyed using those studies. Although one might say that the duration is too long, it's about 15 years of information, but still, this is additional proxy surveys, so to speak, national survey that would help us see the status of people. All these studies reported on the status of people, their caries issues and their caries status. And we have data about 4,000 children reported in the literature. Okay, now we got this data. As I said, we put it in the ArcGIS, and this is what we got. So this is how caries look like in Saudi Arabia, based on the age group. And we'll go through them one by one. So here we can see that the early childhood caries is available in the green areas. So the green parts of the kingdom are the areas where we have data about early childhood caries. You can see Tabuk there up in the north, and then the rest is concentrated in the, so to speak, the middle and the southern part of the country. The eastern province, Riyadh area, Qasim, Mecca, Asir, and there Tabuk. So that's where early childhood care information is available. And it doesn't, the map doesn't say how, at this point, Tabuk, for example, has only one study about early childhood care. That's the only one, but it is mapped there. We know that somebody there was eager enough to explore ECC. Then the age group of 6 to 12, we have only these 5 areas where someone did something, a survey about carers in that area. 12 to 18, Eastern Province and Medina and Mecca are the areas that have information, data about carers in that age group. The surprise is that we don't have data about adults. Okay, we don't know anything about carers in adults. And Riyadh area is the only one that had some data about the elderly. So looking at it, this is how the thing look in Saudi Arabia. We have information collected from surveys over the years, and this is where carers information exists. There are areas that we don't know anything about with regards to the level of carers. Okay, looking at these all together in a sort of a composite picture gives us this view that the dark green areas, which is the Eastern Province, Riyadh and Mecca, have information on 3 age groups, while Asir has 2, with now down in the south, and Al-Qasim, Medina, and Tabuk has data about carers on 1 age group only. The remaining areas do not have any information about carers at all. Can we link this to a factor that being in the academia, I wanted to see, is there any relationship or correlation between data availability and schools availability or presence in the area? And it seems there is, okay? This is how schools are localized in the country. Riyadh area in the middle has 8 schools. Mecca and Al-Qasim each one has 6 dental schools. Then, I'm sorry, the colors are not so it depends. So I can see the Eastern Province has 2, and Medina, Hayl, and Jawf has 1. So if we go back to this map and look at this again, more or less, the data is localized around dental schools. So when there is a dental school, mainly or generally, there is data about carers, except in Tabuk, where there is no dental school. But I know that Dr. Ra'id Bukhari and Wael Sabbah back several years ago did that survey in Tabuk. That's why it showed up. But generally speaking, data are available when schools are available, dental schools. So this table shows that differences between regions with and without carers data. So the column in the middle is talks about school areas that have, or regions that have carers data, and the second one is data when there is no data about carers available. So you can see that population-wise, regions with data have 27 million people. Population with higher education, 2,600,000 almost. The percentage of category A governorates, the mean is 51, while there the mean is 39. So you can see that regions that have governorates A have more data about them. Dental public health specialists are more in the areas or regions that have more data about caries. And Minister of Health dentists also are more in that area. Everything is more when there is data. So the the presence of people, the presence of manpower leads logically to more data present. And that's important to know that, and particularly when dental schools are available, we have 22 dental schools in areas that have caries data. Again, we try to look at the factors associated with data availability, and number of schools stands out. Okay, so there's a higher odds. The odds are higher when there's a dental school in the place. The odds are higher that there is data about tooth decay. Okay, and one means that there is no difference. Okay, so usually population size is not a factor, not a contributing factor here. Population per dentist, the government, nothing actually makes a huge difference other than the presence of a dental school in an area. Except the number of dental public health dentists, which makes a shy contribution, actually, maybe I would say, to the presence of data, availability of data. Again, looking at the role of dental schools and caries data, we can say the more schools, the more data about early childhood caries, 6 to 12 years old and 12 to 18 years old. So again, the data shows that the more dental schools, the more data about caries. What do we conclude from this? This is not the end of the lecture, by the way. This is a conclusion of this section, that regions in the northern and southern parts of the country do not have caries data available. Regions with only 13% of the population have no data available at all. And maybe this is the most important. In regions with higher number of dental schools, there were higher odds of having caries data available. Regions with more dental public health specialists had higher odds of having caries data available. And finally, regions with greater percentage of individuals, which I didn't describe there, but it happened to be that areas with higher levels of education have less data about dental caries. So what are the implications of that? How does that affect our situation of trying to know what's going on in the country? We all know that dental schools usually, generally speaking, at least in the kingdom, have three major roles: education, research, and community service. So the community service role is actually something that I would say that the colleges usually brag about. We go out into malls, we do surveys, and we do education, dental to the public. We see it on Twitter, we see it on social media. So it's something that the schools seems to be happy about doing. So why not organize these efforts so that it comes up with meaningful data that would help us move on and plan for our situation? So apparently, community service activities of the colleges fulfilling their obligation to serve the community, as their missions usually say. They would provide community-based training, or they ought to provide community-based training, because the new trend is that the students need to learn in the field rather than in the class. So why not move on and make that community-based training a learning opportunity for the students? And that, of course, would need changes in the curriculum and the teaching approaches. And by doing so, they will address the gaps in the knowledge about caries. And since they are academicians, they would love to do research and studies about the community. So that would add to their CV, at least, to do more studies and address. But in reality, they would be addressing the gaps in knowledge. So with these three activities, calibration of the people who go out. So there would be a need to calibrate the students or the faculty who would join them, who are going and reaching out in order to gather data about the population. And not only that, but we need to standardize the method by which we collect the data. It is totally unrealistic that we in the MAM would gather information in a certain way that is different than people in Riyadh and people in Jeddah. And then we would claim that we have information about Saudi Arabia. When the method is different, it is sometimes difficult to standardize and to know exactly what is going on, okay? So that's something very essential. And then all of this, of course, has to happen through planned visits to certain areas based on the geographic the needs and the characteristics of the geographic information. If this happens, data surrounding dental schools would be ensured. So if every dental school would establish a system by which they gather information in a systematic way using calibrated manpower, students in this case, then we would cover most of the country with data about dental caries. And that, in a sense, is a proxy national health survey. It's not the ideal situation, but this is a suggestion that if every dental school would be able to gather the data in the region in which it exists, then we would have information about the whole country over time. So, this is not a hypothetical example. The suggestion I'm proposing actually happens in the map. Okay, at our college, university, Imam Abdurrahman bin Faisal University, we are doing exactly what I've just described. We have ongoing assessment and monitoring of the health status of the target groups, which we believe that we were able to reach out to. And we provide preventive services as well as creating access for them. So those who are screened and examined are referred to the dental school to get prevention and treatment. So what does the model say? Basically, what the model worked in a way that we established the community service unit 2 years ago. And I'm sure that most of dental schools have community service units. But the unique thing that happened in our college is that we linked the activities of the dental public health courses with the community service units. So whatever happens in the community service unit is actually fed by the activities that are planned for teaching and learning in the dental public health courses. So when the curriculum was reformed about 3 years ago, this was put in mind that there will be a central community service unit and that the activities would be streamlined. And by the way, I'm afraid Dr. Shammari is not here, Professor Shammari is not here today, but in this reformed curriculum, this is just a side note, we have 2 new courses about cariology. And the 2 courses are taught in the early second and third year, over 2 semesters, and they cover caries from A to Z, from biology and microbiology of it and pathology of caries through prevention and the basic ways of preventing it. Those students who are still not yet able to treat patients would go to the clinic and see patients, and they won't provide prevention themselves, but they would be joined with students who are doing that prevention. So they have early exposure to prevention in their curriculum. So this happens, and I wish Professor was here to hear that. So the dental public health courses, all the activities where students go out to the community to teach and do prevention, which happens in 3rd year, by the way, which is the 2nd year in the dental school, they reach out. But before we sending them out, we standardize them, we calibrate them. So there are sessions for calibration where everyone knows exactly how to do that based on the 2nd square, which is the standardized methodology, the basic screening survey. And the basic screening survey takes the individual as a unit rather than the surface of the tooth, but it is simple, it is easy to learn, it is reliable, and it's not maybe not ideal, but it is a useful tool that we have adopted. So this is how it goes, and then all the information we gather, whether it is related to the course or not, it goes into one body that gathers this data, the central unit, the community service unit. So every data we get does not belong to the course director, does not belong to me who went out, it belongs to the community service unit. So we have one body that deals with the data. Okay, how does this look like when we look at it geographically again? This is the eastern province. This is ملتقى الشرقية, okay? And it has 11 governors. It's 11 محافظة, okay? So you could see that, again, we categorize the same age groups: ECC, 6 to 12, 12 to 18, and adults. So we can see that most of the activities happen in 8, 9, and 10, which is الدمام, الخبر, القطيف, okay? And then sometimes we have 7, which is Ras Tanura, and sometimes we have 6, which is Al Jubail. And these are, by the way, the most populated regions in the eastern province. So that this map shows the biggest one here is Al Hassa. Okay, Al Hassa has a dental school, but they are still in the beginning, so they don't have, I think, much of activities. But most of the activities, as you can see from the map, happens around the dental school because it's easy access, so to speak. But again, the activities actually happens around the most populated areas: Dammam, Al-Qatif, Al-Khubar, Al-Jubail as well, sometimes. So the areas that, and then Nairiya, Hafr al-Batin, these are not heavily populated. Well, I'm not saying that they don't deserve services, but the reality is that the activities happen around the heavily populated areas. So again, if this happens in Dammam and happen in Riyadh, which has 8 dental schools, and it happens in Mantaqat Mecca, which has 6 dental schools, then we would be able to cover the area as much more than we do now. Based on the data, I'll finish maybe in 2-3 minutes. Based on the data we have, we were able to see, educate and examine about 10,000 people in the past 2 years. And part of the activities that we also include is prevention, but we have some bumps in the way, but we're going back on the road, inshallah, very soon to providing preventive services more than actually referring them only to the dental school. Looking at, again, those that were geo-referenced are about 7,000 people. Those we were able to locate where exactly they are. So what are the conclusions, directions, and suggestions? Again, I'm emphasizing what I've maybe said several times through the presentation, that dental schools can contribute to fill the knowledge gap and help in needs assessment at the same time as they are fulfilling the community service. So they are going to the community anyway. So why not have that organized, have that standardized, have that properly documented through a unified system, that all schools, and here suggesting that all dental schools come together and decide on any form of data collection and a standardized way of calibrating the examiners who go out and collect data so that we have a unified way. But the challenge here is that we don't say that data I collect in Dammam is my data and data collected in Jeddah is Jeddah's data. This way we'll go back to square one. We want wherever the data is collected is the Saudi Arabian data. And that is where we have Saudi Arabian data about caries coming from everywhere through the dental schools. And this collaboration between academia and Ministry of Health and the Saudi Dental Society as a unifying body, so to speak, that gathers all dentists in one place and under one umbrella would hopefully move things forward. We could have a national health survey or a proxy national health survey through dental schools, through collaboration, through standardization of the methods, and through sharing information as the Saudi Arabian data on caries. Thank you very much. Thank you.
Thank you, Dr. Ansari. Thank you for this very informative lecture. Actually, it's not only informative, it is also challenging and inspiring at the same time, and it triggers in us some feelings that we need to do something and give us some ideas and even the path how to go.
Thank you.
Thank you very much.
Thanks.
I think we are tight in time. I don't know if you have any question. Okay. On behalf of the organizing
Sure.
committee, I would like to give you a sign of appreciation. Thank you very much, Dr. Ansari.
First, I want to thank the organizing committee for inviting me here. It's a pleasure to present Dr. Helen Rogers. Dr. Helen Rogers' present appointment is a doctoral research fellow funded by NIHR School of Clinical Dentistry, University of Sheffield, since 2014. Academic Clinical Fellowship in Pediatric Dentistry from 2014 to 2017, and Dental Core Training in Pediatric Dentistry from 2013 to 2014 at Charles Clifford Dental Hospital, Sheffield Teaching Hospital. She has a current research project as investigator, principal investigator, research assistant, and reviewer, which was already completed from 2015 to 2017. She has relevant publications already published for the past 2 years. Her current academic role of responsibility includes assistant editor for the International Journal of Pediatric Dentistry, a founder and chair of Child Oral Health Northern Research Collaborative, and peer reviewer for the International Journal of Pediatric Dentistry. Let's all welcome Dr. Helen Rogers.
Thank you for that lovely introduction, and thank you for inviting me to speak to you a second time on a topic that is very important to me. This is one of my main research areas, and I know that economics is perhaps not everybody's favorite topic. I'm not trying to persuade you to all become health economists, but perhaps if I could just spark a bit of interest in this topic, I'd be happy with that. So the aims and objectives of this talk are really just to give you a bit of a flavour of economic evaluation. We have got some issues with economic evaluations in child oral health research, and I'll cover these. I'm not going to go into detail about which treatments are more cost effective than others, and you'll see the reason for this is that we actually are really missing quite a big chunk of data that we really need. And I'll also just talk about some of the challenges that we have for research in this field. So first of all, what is economic evaluation? Let's first think about the condition. Let's think about caries and how it impacts on children. We know that children with Caries have difficulty eating. They often get food stuck in their teeth. They often have to eat on one side of their mouth. They maybe will eat more slowly or more carefully. They may only choose certain foods to eat. We know that caries can wake children up in the night. They can have disturbed sleep, which can in turn affect their growth and their development. We know that it can make speaking quite difficult as well. And we know that children who have caries will often fall behind with their schoolwork, and they often will miss school. I think the most commonly quoted figure is that in the USA, almost 50 million school days are lost each year due to caries. So really, really big impacts on children's lives. But let's think a little bit wider than that. Let's think about the impacts of caries on families, not just children. Let's imagine that your child has caries. They're waking up in the night. It's going to impact on your life as well. You're going to have to buy them some painkillers, some analgesia. That's a cost to you and your family as well. Perhaps if you take your child to the dentist for lots of dental appointments, it's the cost of transporting yourself to those appointments. In the UK, we have to pay a lot of money to park our cars as well, so that's another cost to families. You also have to ask your employer to have the day off work if you have to take your child to an appointment. So it's approaching your employer, and sometimes there can be financial impacts in doing so. And if you have other children, you may need to find childcare, somebody else to look after that other child while you take your child to the dentist. So actually quite big impacts on families, much more than we would normally think about. And what about the impacts on society as a whole? In the UK, for children to have a general anaesthetic, it's the most common reason for a child to have a general anaesthetic is due to caries. They do more operations to remove children's teeth than operations to fix a child's broken bone. It's the most common procedure. So the impacts are really significant on society. Financially, there's also parents that take days off work. There's an impact for their employers. Their employers lose out when parents have to take their child to the dentist. There's a huge burden on healthcare services as well, and I've been hearing as well that in Saudi you have a similar problem to us in the UK with long waiting lists, which can be a real burden on families and on the system. And of course, I think overall, I think you'll all agree that caries does have significant impacts on the lives of children, their families, and society. There's lots of different impacts. It's not just toothache. So next, let's think about who pays for the dental care. There's various different systems. I know that here in Saudi, your Ministry of Health funds a lot of dental care. In the UK, we have our National Health Service. And often these systems are funded through taxes or through other means. A lot of systems also use insurance-based systems, so where the family will pay an annual fee, and in return they can claim back the costs of the treatment that they've had. And some families prefer to pay privately. They'll pay as they go for the treatment that is required. So what is an economic evaluation then? Well, it's an approach to weigh up the costs and the benefits of an intervention. And when I say an intervention, I mean it could be anything from fluoride varnish application, toothbrushing initiatives, maybe posting out toothbrushes and toothpaste to families. There's a whole host of different interventions. Things like water fluoridation as well is still an intervention. So why do we need this information? Well, it's actually very important to make sure that the people that make the decisions in our governments and for insurance companies, we should be providing the most cost-effective treatments. This means that we're using the money in a most effective way, and it also informs our clinical decisions as well. And I think it's also the best option for families, particularly if they're paying privately. They want to make sure that they're getting the best option. Now, these economic evaluations are often carried out alongside a clinical trial. So if you're carrying out an investigation to find out the effectiveness of a new preventative treatment, you would carry out a clinical trial, and you would often do an economic evaluation alongside that trial. And as you can see from this chart, the ideal intervention falls into category C. So it's a more effective treatment or a more effective intervention, and it's also less expensive. That is the ideal. Unfortunately, often our economic evaluations find that perhaps treatments are more effective, but also more expensive, in which case the decision maker has an important and slightly difficult decision to make. But also sometimes we find that our treatments are less effective, in which case we would completely not consider them any further. So this is really important because every source of funding has got a limit. We like to think that the National Health Service can keep on paying and paying and paying, but actually this is not going to happen, and we will run out of money if we keep on treating patients in ways which are not cost effective. It makes sure that our resources are used very efficiently. It also makes sure that insurance companies aren't paying out for treatments that are perhaps not the best treatments. If insurance companies have to pay out high costs, then actually what will happen in turn is that in future years, families will end up having to pay more to get the annual cover from insurance companies. So it's in everybody's interest to have the most cost-effective treatments provided. And I think as well, most importantly, it also ensures that children are receiving interventions that provide the greatest improvement in their oral health. So it's not just about the costs, it's also about the effectiveness, and that is what the children will benefit the most from. So if we think about how we might do an economic evaluation, first thing that we would think about is measuring the costs. How do we find out what costs are involved in our new intervention? So we have to think about things like the salaries of the dentist, the salaries of the dental assistant, the salary also of the any administrative staff that you might have, a receptionist. We also have to think about that in relation to how much time the intervention takes. So for instance, applying fluoride varnish, it might only take maybe 20-30 seconds. It's not long at all. To apply a fissure sealant, it might take you a couple of minutes. So it's one of those things. Different treatments take different length of time, and as such, they'll take a different proportion of a dentist or a nurse's salary. And what about the resources that we use as well? I'm not just talking about disposable resources like things like etch or fissure sealant. Also thinking about our equipment that we use, the cost of autoclaving our equipment, perhaps also the cost of renting out a building that we are using, perhaps if you have a mobile clinic, the costs of running these mobile clinics as well. It's thinking outside of the box a little bit. It's not just the cost of the treatment, it's other things as well. Another thing that we often consider as well in economic evaluation is the impacts on the families. How much cost are families having to pay? So if families are taking a day off work, you know, they have to factor in these important features as well. So it's a combination of all of these things, and we call this process micro-costing because we are literally looking at the finest microscopic details of what costs are involved, and that's how we know that it is absolutely accurate. So let's think now about how we measure the benefits and how we know that these treatments are effective. So there are different ways. So one of the most common ways is for people to do a cost-effectiveness analysis, and you may have seen many of these in journals and publications. And in these sort of studies, the benefits are measured in natural units, so things like DMFT. So we know we're measuring a natural change in a direct way, or perhaps we measure how many children are caries-free, how many children we have managed to prevent caries in, Or one that I really like is a change in oral health-related quality of life. Has our intervention made the child's oral health-related quality of life better? And I think that that one is a particularly important one, and one that is often forgotten. The next type of economic evaluation is what's called a cost-benefit analysis, and this type of approach is often used by policymakers. So if you're introducing perhaps a water fluoridation scheme or something on quite a big high level, then you might think about doing this sort of analysis. And it's quite simple. You basically measure the benefits in money as well. So you're not focusing on an individual level. You're looking at the financial benefits. So you would normally do quite a simple sum of the money that you have saved by introducing this new intervention, and from that subtract the cost of delivering the intervention. So you end up with a sort of an average figure. And the final type of economic evaluation is what's called a cost-utility analysis. And this one is one which is growing in popularity, and I think it is probably the future of economic evaluations. For these, we measure in what's called utilities, and there are different types of utilities. The most common one is a QALY. I'm not sure how many of you have heard of QALYs, but if you haven't, I'm sure you'll be hearing a lot about them in the future. So what is a QALY? So it's a quality adjusted life year. And a lot of decision makers in governments and insurance companies actually prefer this type of analysis because it actually combines both the length and the quality of life in one unit. And obviously, quality of life for us is oral health related quality of life. And this means that we can actually get a real grasp on how our treatments are actually impacting children directly. So obviously length of life in caries is something that we're not really affecting. Fortunately, not many of our patients have a shortened lifespan because of caries. But the beauty of this scale is that it can be used for other conditions as well, conditions like cancer, where your length of life is going to potentially be impacted. So that's one of the great things. You can compare a QALY in caries to a QALY in cancer, and it's why it's so helpful for governments to make sure that resources are directed to conditions that create the greatest improvement in quality of life and length of life. And they're measured on a scale of 0, which is death, to 1, which is full health. So if you have a QALY of 0.5, then you're sort of at halfway health. And you would report it in terms of the cost per QALY gained. So it might sound slightly complicated. I promise it is quite a simple concept once you get your head around it. And it is something that is going to be a measurement of the future. There are different tools that you can use to measure QALYs, and these have to be validated and formed in a correct way. And I believe that children should be involved in the development of these measures. There's one measure at the moment called the Child Health Utility 9 Dimensions, or CHU9D as we call it, and it has been used in some dental trials so far. It is a generic measure, so you can use it for children with cancer as much as you can use it for children with caries. You can use it for any dental condition or medical condition. And it's validated, and it's being used across the world now. And the only problem with this measure is that I don't think it is as sensitive for children with caries as it could be. I think that we perhaps need a specific dental utility measure. But all it is, it's a very simple questionnaire that a child would fill in, and just by getting them to fill that information in, you're actually gaining QALY data, which can be of great importance. So let's think about a trial where this has been used. So yesterday I mentioned the seal or varnish trial. So this is a big trial in Wales where they were comparing fissure sealants and fluoride varnish. And they found that clinically there was no significant difference in effectiveness in preventing caries. which is great, but they did find that there was a difference in the cost effectiveness. It didn't have any impacts on their quality of life. One did not make an improvement more than the other, but there was definitely a difference in the cost, and we found that the difference in cost was about almost 72 pounds, which is about 376 of your riyals, which is obviously a big difference, and that's per child when you take into account every single cost that could possibly be involved, including the cost to parents and families. So that means that the fluoride varnish is a cheaper option and just as effective. So it's not something that, I'm not saying that we should stop doing fissure sealants completely. Obviously we have to make these decisions individually for each patient, but it is information that is valuable to decision makers and insurance companies. The other thing that I want to get across is that it's so important for us to be involving children, not just in economic evaluations, but in research overall. There has been a real big push, particularly in the unit where I work, to start doing research with children and not on children. So the difference is if we do research on children, perhaps we're just gaining DMFT data. We're just looking at their teeth, and we are researching on them. If we do research with children, we are listening to them, we are gaining their thoughts, we are gaining their input. Perhaps we're asking them how it's affecting their quality of life. How does something feel? These sort of things are so important, and I think there is a big shift now in starting to do more of this research with children and getting children actually on our panels to help us plan our projects as well, asking children what they think. It's a really big thing, and it's something that was mentioned in the UN Convention in 2006, the importance of involving children in research. We have to appreciate that the children are the ones that are experiencing this condition. It's them that has the caries. They're the experts in this condition. They are the ones that are experiencing it. Why do we not ask them? And there's lots of different ways that we can involve children in research. Obviously, qualitative research, we're asking the child directly. Perhaps we're doing interviews with them. Perhaps we're doing focus groups. Perhaps we're getting them to draw pictures. But the other thing is often questionnaires and surveys, and these are so easy to do. We have so many validated surveys for different age groups, very simple to complete, and I think that we can get some really valuable data from these. There's one measure that we have developed in Sheffield called Caries QC Questionnaire for Children, which was developed by one of my colleagues, Fiona Gilchrist, and this measure is a oral health related quality of life measure specifically for children with caries, and it's being used in lots of trials now around the world. And of course the other measure that I mentioned before is TU9D, and that one has the added benefit of giving us the QALY data. So now let's think about economic evaluations in child oral health research. What is the problem? Why am I talking about it today? Well, there's historically not been very many economic evaluations. This number is starting to increase. The problem is that in recent years, nobody's actually appraised the quality of these economic evaluations. Nobody has looked at whether we are involving children in these economic evaluations. And because of this, we actually still don't know which prevention interventions are the most cost effective. Information, even like the trial that I mentioned to you there, it's still flawed. There are still problems with these economic evaluations, so there's definitely room for improvement. So I decided to carry out a systematic review of both the quality and also the scope of these economic evaluations in child oral health research. So I looked at all the databases I could think of and did a search to include all the full economic evaluations with a focus on oral health that involved children under 18 years of age. And I appraised the quality of these papers using two different techniques. So these are both checklists that are specifically developed. I'm sure you know about things like the consort guidelines. These are similar guidelines, but not for trials, just for economic evaluations. So we have a Drummond checklist and another one on reporting quality called the Cheers checklist. So I used both of these measures. They're quite long guidelines. They weren't the easiest to use, but both very important. I also looked at every paper that we included to see whether they'd involved children in their research at all. So we had a team of 6 reviewers that were all calibrated, and some of the papers were in languages other than English, so I recruited some translators to help me. So I found that from an initial search of 2,761 papers, I managed to whittle it down to just 46 papers that met all the inclusion criteria. A lot of the studies that I found initially, they were either involving children who were over the age of 18, so young adults, or some of them were not full economic evaluations, or they were perhaps just what's called a cost analysis or an outcome analysis. They weren't actually looking at costs and benefits. So what did I find? Well, fortunately, caries prevention was the most common condition to be reviewed in economic evaluations. And as you can see from this chart, fluoride delivery and more comprehensive preventative programs were the main topic. So perhaps they were comparing a program of doing toothbrushing in schools and applying fluoride varnish with perhaps a program where children just watched a video in school about oral health. And these sort of things, there was some looking at sealants. There was a couple of papers on orthodontics as well, and one on dental anxiety. But definitely, caries prevention was the most common, which was a good thing to see. Most of these studies were cost-effectiveness analyses, so these are the ones where they use natural units, so they measure the change in caries or the change in oral health-related quality of life. The thing that I was quite sad to see was that most of the outcomes were reported by clinicians, so most of the research was on children, not with children. Only one study involved children, and this was simply in a non-validated satisfaction questionnaire, which again was very flawed. I also found that there was a really big range of lots of validated measures that were used to record these outcomes. As I say, DMFT, DFT, DMFS, and the list goes on. And there were also some non-validated measures that were used, which again, it's a shame because it does make things a bit more complicated to analyse. When I looked at the quality of these papers as well, there were quite a lot of flaws. Out of all the 13 criteria of the methodological quality, there were some problems in recording the costs in particular. A lot of the costing, the micro-costing had been flawed. Perhaps the authors had not looked at all the possible costs. They hadn't done that perfect micro-costing that we would expect. But there were some more positive points as well. I think sometimes the benefits were actually documented rather well. And as you can see at the bottom, our reliability, because there were 2 reviewers for each checklist, it was actually fairly high. We had quite a good CAPA scores. And when we look at the reporting quality, this was slightly better. The sort of median score was about 18 out of 24. Most of the studies had a really good abstract. They correctly identified themselves as being an economic evaluation, but actually very, very few papers reported any conflict of interest, which of course could introduce some bias into the way that we interpret the figures. So this is certainly one area that needs to improve. And again, our reliability, our CAPA statistics, they were okay, satisfactory. So from this review, what did we find? Well, we found that there was a lack of high-quality economic evaluations. There were definitely some flaws in the methodology and also some flaws in the reporting of these evaluations. It was so difficult to compare the outcomes in terms of prevention. And as our previous speaker was saying, one of the big problems for this is that everybody is using a different measure. We have some people using DMFT, some people using DMFS, some people looking at number of carious teeth avoided. The list goes on. There's so many different variations, and it's so hard to compare these outcomes. One thing that was a real problem is that so few studies, almost all of them, didn't include children in the development of the study or in the actual sort of the outcomes of the study. Very few studies actually used oral health related quality of life in their reporting. I think this is a really important area. I think oral health related quality of life, if it's just a simple questionnaire, there's nothing more to it than that, and you can get some really valuable and meaningful data. And one thing I thought was really interesting was that there were no economic evaluations of dental trauma or molar incisor hypomineralization interventions. We literally have no information about which treatments are the most cost effective in dealing with these. At least for caries prevention, we have some vague idea. There are some evaluations out there, but for these two massive areas, I mean, think how many patients with trauma that we see, and nobody's looked at the cost effectiveness of these interventions, which I think is really, really interesting and definitely something we need to improve. So what are the challenges for future research in this area? Well, first of all, of course, I think involving children is definitely something we all need to be better at. Especially in economic evaluations, I think it's incredibly important that we make sure that we are using their expertise as the sufferers of the condition and using their expertise in guiding our research. I think it's important that we use more measures, outcome measures that are developed with children, things like the caries QC and the TU9D that I mentioned. And I think child-reported oral health-related quality of life is the way forward. I don't think that we should be asking parents if there is an opportunity to ask the children themselves. In terms of the quality and scope, for the future, I think we need to have more economic evaluations. I would encourage you all, if you are carrying out any clinical trials, please consider the economic evaluations alongside it. And I think it's important that we make sure that these are really high quality economic evaluations, that we are considering all of the costs, that we are reporting our conflicts of interest when we are publishing this information, and that we are maybe using our guidelines as well, these checklists, before we publish. And I think that would certainly help to improve the quality overall. And in terms of outcome measures, I think I completely agree with the previous speaker. This is a real issue. There is a study at the moment called the OutMac study, where they are now trying to come up with a standardized set, internationally, a standardized set of outcome measures. And I would encourage you all to look out for the results of that study. The protocol is published, but we are still awaiting the results. And what they are trying to identify is a set of 7 outcome measures. Obviously, I'd rather it was just 1 or 2 outcome measures, but there's so many different types of outcome measures for caries. I think 7 is what they have agreed on. But even if we just use those 7 outcome measures internationally, I think we can share our research and share our findings and hopefully create more improvement in children's oral health. And the final thing I feel is that it's very important to gain this QALY data, not just oral health related quality of life, but QALYs as well. It's definitely the way forward, and it's so important for decision makers in the government and in insurance systems. I think perhaps the TU9D that I mentioned before, as I say, it's perhaps not the ideal measure for QALYs for children with caries, and at the moment myself and the research team in Sheffield, we are trying to develop a child-centred measure that is perhaps directed a little bit more towards children with caries, and I'm hoping that that will make things a little bit easier for us all in the future. So just to summarise, I think economic evaluations are absolutely crucial. I hope I've inspired you to consider this a little bit more. I think it's important to just determine the cost effectiveness of our interventions, to inform the right people about which way we need to be going with our treatments, and to make sure that patients are receiving the best interventions. And I think a collaborative approach to this is really, really important. Just before I finish, I'd really like to just take the opportunity to say, really, I've been quite inspired by all of your interns here. They all have such a passion for learning, and they are all so keen to continue their studies, which is something that perhaps most of our trainees in the UK don't do, and I'm quite very impressed with it, really. I want to just say that we have a range of courses at the University of Sheffield for master's programs and PhD programs, and we would love to invite you to consider coming to join us in Sheffield. We have also got the Masters in Clinical Dentistry and Pediatric Dentistry course, which myself and Helen Rodd and Chris Deary are involved with. And yeah, we would love to see you in the UK. Thank you.
Thank you, Dr. Helen, for your valuable and informative presentation.
Thank you.
And on behalf of the organizing committee, we would like to honor you with this award, a certificate of appreciation.
We have a break now for almost 15 minutes, no?
Not now.
Not now,
Not
later
yet.
on? Okay, sorry.
Now we would like to introduce the President of Saudi Dental Society, Dr. Fahad al-Shahri, to acknowledge and reward one of the employees of the Dental Saudi Society. Dr. Fahad al-Shahri. On behalf of Scientific Committee, we would like to announce the winners of poster competition for the poster prize. The winner of the poster prize for the third place is Dr. Daniel Madi. The winner of the poster prize for the second place is Dr. Muna al-Musawi. The winner of the poster prize for the first place is Dr. Haifa al-Hussein. Congratulations, doctors. Now we will have a coffee break and we will come back at 10:45.